Welcome to the Seniors Flourish podcast, where it's all about helping occupational therapy practitioners working with older adults be the best they can be. And now your host, Mandy Chamberlain.
Welcome, everyone, to the Seniors Flourish podcast. This is Mandy Chamberlain, occupational therapist, and the host of the show. We're talking all about working with the older adult. And today we are talking all about acute care. And so today the guest is Sarah Stromsdorfer. She's an occupational therapist, and she also blogs at myotspot.com. And she's been a past guest, which has actually been the most downloaded episode of all the Seniors Flourish podcasts, Sarah. Did you know that?
Oh, no, that's so exciting to hear. And thanks for having me back. I love being on this podcast.
Yeah, I'm really glad you're here too. You know, the last episode you were on was focusing on occupational therapy or occupation in occupational therapy. And I think that's, it's just a topic everybody's we want to do that. So we want to get back to our basics and be more occupation based. So I think that's why it's one of the most downloaded. But so I am glad you're back with us and talking about acute care. So that's awesome. So if people have not listened to that episode, and I'll put that episode in the show notes if you guys want to check it out. Why don't you tell everybody a little bit about your OT journey and what you're doing now?
Yeah, definitely. So I'm originally from St. Louis, and during my undergrad years back in 2008, 9, 10, 11-ish, I was working as a nurse assistant in an inpatient rehab hospital. And at first wasn't really sure what I wanted to do. I knew I was going to get a psychology degree and maybe thought about nursing. But then I just really started seeing, after working with patients every week, just the progress that they were making with therapy, and was really excited just to see every day, just, wow, the therapists, occupational therapists and physical therapists and speech therapists, they're really the ones making this progress. And I figured, well, I'm doing ADLs every morning with them, so maybe I'll become an OT. And now realizing I didn't really do the greatest ADLs because I was kind of doing everything for them. But we're like, okay, I'll be an OT. So then I graduated from University of Missouri, St. Louis with my bachelor's, and then moved to Atlanta and started attending Grinnell University for my master's in science and occupational therapy, and have been working the past 2.5 years in inpatient rehab and acute care. And then I also started my OT spot after realizing in field work there was not a lot for the adult-based occupational therapist. So made that blog for the adult-based OT, and also a lot of OT school and fieldwork issues too that weren't really addressed as much. So it's been a little whirlwind in acute care rehab. Also, I did a little bit of geriatric outpatient in addition. So there's a little hodgepodge of that on the website.
And that's cool. And that's kind of one of the reasons why I started Seniors Flourish as well. It's like you're looking for those resources and you can't find anything, especially now when you have Pinterest and you have all, it's so easy to, Google something and feel like, how can I get some treatment ideas, or how about these professional issues? And there was so many amazing pediatric websites out there.
Exactly.
That it's just
so many pediatric. Yeah. And it's like, where are the adult websites?
I know. Well, let's be honest. Pediatric OT is freaking fun. You can do Play-Doh and so many, there's so many fun things. And so it's but there's so many of us working with adults and older adults. It's we got to represent.
Exactly. So I'm so glad to have found you too, just to have this collaboration on just the adult and geriatric occupational therapy resources. It's so fun just being able to provide these for people, especially like you, when you were working on your own as a new grad, and there just wasn't a lot in some of these home health settings and clinics. So it's good now with the internet to have this.
I know. Thank God for the internet, seriously. But okay, so today we're talking about acute care and your experience in acute care. I keep calling it cute care. I don't know. Acute care.
It's a very cute care.
Okay, how would you describe what acute care is? Like if someone is not familiar or they're from another country where they don't maybe necessarily use the term acute care, how would you describe it to someone?
The way I describe acute care to someone who's not as familiar with it, or even to patients that are in the hospital, is it's the setting that you first go when you're in the hospital after you've been admitted for an illness, injury, or surgery, where your main purpose is to get medically stabilized before going home or before going to maybe rehab or a long-term placement, possibly. And while people are in acute care, some people benefit from OT and PT and sometimes speech to begin the rehab process. If the person is completely independent in the hospital, the doctors may not even order them, but sometimes they do, just to have us check and see how are they functionally, are they safe to go back home. And so while they're in acute care, when we're working with them, we work to prevent further decline and also work to increase their independence back to their baseline.
Mm-hmm. Yeah, that's how I describe it too. But you always, because I haven't worked in acute care in a very long time. So you always are kind of interested in like, how would you describe that? So what are some qualities? I mean, it's such a fast-paced setting. So what are some qualities that you think OTs who are interested in working in this kind of setting, what kind of qualities do they need, or some things that are probably helpful?
Definitely flexibility, since in acute care, since it's so fast paced and it's so crazy, you don't have set scheduled therapy sessions because the patients, they're there to get medically stabilized. So if they have any sort of procedure, even if a doctor's just popping in, we kind of are second to that. So your day can very easily change, or your caseload can kind of fall apart if everyone's off the floor getting an MRI or dialysis. So having that flexibility, definitely. Also, good clinical judgment and problem-solving skills are really important with a bit of a medical background, because I have found in acute care, you're seeing a lot of new diagnoses and possible contraindications for therapy, and there aren't always clear-cut notes from the doctor saying hold therapy. There's never really a hold therapy note like in rehab. So you kind of have to piece together all of their lab results and vital signs. So kind of making sure you have those problem-solving skills, so you're not going in and seeing someone that's unsafe to be seen. And a lot of hospitals will have written handouts on lab values that have those numbers. So when you first start in acute care, definitely see if you can track down one of those, and asking other therapists for help too is really helpful.
Yeah. Yeah. I was just going to say, knowing those lab values, and it's so funny because like I didn't start out in like an acute care setting. I started out in home health, which a lot of people may have heard my story about starting out in home health. But, I think those are sometimes the pieces that like you learn in school, like, you learn all the lab values and you memorize all these things and why it's important. But like in acute care, it's so important. And like, I feel like that was maybe a piece that I missed as a brand new grad, was like that whole having that really good medical background of what the lab values do and how they directly impact. Cause you see it's so apparent in acute care, saying like,
they're so
white
much
blood
sicker.
cell count is, yeah. And it's just so in your face, and you quickly learn why it's important to know those lab values, or looking at those little things. Yeah.
And the equipment as well. And I will say there's a really great, and a lot of OT programs have you purchase this textbook, the Acute Care Occupational Therapy textbook. It's that really thick orange textbook. It goes through all the lab values and all the lines and kind of everything you need, and kind of covers it by diagnosis. So if you're starting acute care and you may not have a lot of great resources, dust off that book and it will save you.
I know. And it's just like you kind of have to jump in and like you learn some of those things so fast. But the equipment is I think can be very intimidating if you're not, maybe even if you didn't have like a field work or in acute care. Yeah, there's just so much, I think, to learn. Alarms are beeping and you're like, did I make that go off? Or how do I even turn this thing off? Like, you're like pushing buttons or waiting for the nurse.
And just come out of this person. And
I know. Yeah. Am I going to like pull on something too far? You're like pulling on an IV, like I mean, it's like catheters and IVs and I mean, monitors. And it's just like feeling, it takes a while, I think, to feel comfortable with. Yeah. Yeah. So what kind of, I'm sorry.
Once you're familiar with all that stuff, you'll be fine. So for anyone doing a fieldwork rotation coming up, don't be worried. Your instructor will tell you everything, hopefully.
Hopefully that you need to know. Yeah, definitely. So what kind of diagnoses do you typically see in your, I mean, I know all facilities are going to be different based upon like what their hospital level is. But what type of diagnoses do you see typically?
So we are a small community-based hospital. We don't see any trauma patients, but we have pretty much everything else from cardiac and pulmonary conditions like CHF, COPD, acute strokes, a lot of people post-falls, post-op ortho patients since we have an ortho unit. We also have a surgical floor where people are there for other surgical procedures. Sometimes we get people with just altered mental status and the family's trying to figure out what's going on and like could be a UTI or just anything off with those lab values at home. We also have an oncology unit. So we have oncology patients and basically anyone hospitalized who gets OT orders other than trauma patients.
Okay. What do you think are some of the challenges of every setting has their challenges, but like, what do you think specifically to acute care?
For me, I would say the hardest thing is meeting productivity because as we said earlier in acute care, it's so crazy and the day can so easily fall apart. A lot of the time I spend in the morning is combing through all of the patient's charts to make sure there's nothing that indicates that I can't see them. And so you spend all this time and then you go up to the floor and they're off the floor for the day. Or they might refuse therapy because they're exhausted from all of the people popping in earlier in the day, especially trying to get my treatments in the afternoon. Everyone's so exhausted. So meeting that productivity, ours is only 60%, but it is so crazy how hard it is to meet that with writing up all your evaluations and running all over the place, getting equipment. But some hospitals I don't think have productivity requirements and other ones might have even a stricter amount of seeing maybe 10 patients a day. So with the productivity, I would say if you're interested in starting in acute care, check to see what those demands are and see if talk to other therapists there if you're there to interview and see how they feel about it. Because I have heard other hospitals are harder than others.
Yeah. Well, and then obviously depending on how the hospital's set up, like you may be going up and down floors, like up the steps, down the steps, up the steps, down the steps, get a good workout for the day. But,
and then you sit down and you look at your units, you're like, oh no.
Yeah, I know. It's hard because, well, all of our settings I think have their challenges and every setting has that. But yeah, acute care. I know I did one of my field works and I was in acute care during the field works. And I remember that whole thing. And when I was, a student, you're obviously just trying to learn and trying to figure out, like, they didn't have like ADL equipment on every floor. And so like you're hauling it, you're running and then you're like, oh, son of a, I forgot
I need the socket and it's 3 floors down.
Yeah, and you're like, oh man. But then the patient's actually in the room and he's going to go to MRI and you're like, I need to get this done. And it's just like, maybe some, foresight and planning a little better would have been, but I figured it out. But it is hard because you don't actually know exactly what you're going to be getting into for the day because do you do a lot of evaluations, right? Like how many evaluations do you see in a day?
It's a lot of evaluations. So typically we'll see anywhere from maybe on a low eval day, if there are a lot of OTs working, maybe 2 evals and several treats. Or if we're low on OTs, we'll maybe have like 5-6 evals, maybe more. And it's just you walk in and you just don't know what you're going to run into exactly.
Yeah, it just ends up being kind of crazy. And it's just been because of this fast pace. It's like you're trying to do so much in such a little bit of time, really. I mean, it's not like you're in, inpatient rehab where you have this whole long treatment session
You have a nice scheduled.
Yeah. And it's just like trying to get as much as you can in that little bit of time. So what kind of assessments do you guys use in acute care in your facility? Every facility is so different. Some people don't, some don't even have any formal assessments, but what do you guys do?
Yeah, so our basic evaluation, it's the same as our inpatient rehab eval. So it goes through the whole FIM, but we don't have to FIM the patients in acute care. But I kind of base it on that. And then if we have a G code, we'll use the Boston University AMPAC 6 clicks.
Yeah.
So it's kind of a mix between the FIM. I like it. I used to use the Barcel when I worked in ALF settings, and I kind of liked that one a little bit.
Yeah. Yeah, so the whole 6 clicks thing, I've never used it, but people are always asking me about it. I'm like, actually, I've never had any personal experience with the 6 clicks, so I'm always kind of
It's pretty easy. It's really short.
Yeah, and it has some validity to it. I mean, like it has research to support it, and you feel like, can you really get that much information from, something that's short? But I guess you can. You know what I mean? Like good info. Interesting. So why do you like acute care? Why do you think it's a setting that you've been working in for the last couple of years?
Well, I love it because we said it was very crazy and unpredictable, but I love the flexibility that if I want to set a certain amount of hours of just running all over, I can. And then if I'm ready to document and take a break, I can sit and document. And the day is never boring. It's every day is a different day. And you meet so many people from all different walks of life. And you really feel like you don't get that kind of rehab camaraderie as much if they're only there for a couple of days, but you really feel excited about if a patient's appropriate for rehab and maybe their doctors are trying to send them right home, but you kind of, with your documentation and talking to case management, you set the stage with PT to actually get them into rehab where they're safe to go. And you're really happy for them to get rehab. And I also really love the autonomy to be able to keep patients who I feel are appropriate for therapy. And if patients are not appropriate, so if they're independent, I can provide the necessary education and discharge them versus other settings I've worked at. Sometimes you're kind of forced to keep people on for a longer time that aren't appropriate for OT. But in acute care, there's none of that. It's like if they need therapy, you keep them on. And if they don't, then you can discharge them and just make your discharge recommendations. And I love the fast-paced nature of it too. I love how fast the day goes by. And I think I'll always be in acute care for that flexibility and autonomy and just the excitingness of it.
Yeah. There is an exciting factor because it's like one of the things, like I remember feeling like I feel stressed, but also I was a student. Like I shouldn't say I did work in acute care, but I worked in a really small facility. So, acute care, there was no like productivity standards. I did outpatient and you're like, hey, want to pop on over and see some people in acute care? It was like that. So I'm talking about when it was like the fast paced acute care. I remember feeling kind of like stressed and trying to figure it out, but I remember the day flying by. You're just like, oh my gosh, I just saw 8 people and dominated that day.
You're like, how am I going to get out of here on time? Like, I still feel like I have so much to do, but like, it's just, you really can kind of plan your day pretty well.
Yeah, I know. So what kind of interventions do you typically use? Or like, what does a typical like intervention look like or treatment session?
My main goal for all of my interventions, since the patients are really not getting out of bed unless it's with us or physical therapy, I always try to have some sort of functional mobility aspect with ADL retraining. So if a patient is lower level and can only tolerate maybe their max assist times 2, but I'll really try to at least sit them up edge of bed, really work on that core while doing an ADL, maybe grooming or oral hygiene. And if a patient is a little bit higher level, I'll try to at least do a bedside Commode transfer, work on that. And people just love to be able to sit on a bedside Commode when they've been doing the bedpan with nursing for so long.
I would. I'd be like, this is heaven.
You could actually have a bowel movement. And then if they're even higher level, but like maybe they're meniscus, like I'll try to get them into the bathroom, even if it's just standing at the sink, brushing teeth, washing their face, or doing a toilet transfer. And for higher level, we can't do a lot of showers if they're hooked up to a lot of things, but even just stepping in and out of our shower, doing some transfers. Just kind of getting up and moving is the biggest thing that I try to do.
Yeah. Yeah. I mean, it's so important because obviously we know that like we need to get them up, sitting up, getting up, moving if we can. And, there's, it's really tricky in acute care, I think, as well. Like, because there is a lot of research to support like getting people out of their hospital gowns, but you're in acute care when you have like a billion cords and you're kind of at the mercy of,
All of
the equipment. And so it's like, it depends on what level they are. Like you said, are they low level? Are they, and, trying to get them. And I always found, you can be a bit more, I don't know. I think you can be more occupation based in like acute care just because you're really sometimes working on some of those really basic, you're just getting them moving. You're getting them performing those occupations. You're moving them around. It's just like, do you find occupation-based activities difficult in acute care, or do you find it, what do you think about that?
I think it's almost easier because a lot of times people don't get them set up to brush their teeth or wash their face. And so just doing that mobilization part first and then having to do their grooming or even trying to take socks on and off edge of bed is so hard for people. Like, oh, we're really working on your core and your sitting balance. And if they were doing it before at home and they're having difficulty, I might not even bring the socket. I might just have them practice it for their workout almost. Yeah. So a lot of times you're like, wow, this is really hard. Like, oh, but it's occupation based and they feel like they got a workout. And I used to when I first started, I'd bring in the TheraBand and everything. But now I'm like, well, let's just do as much self-care as we can. And then I'll give them a home exercise program to do while they're in their room by themselves. Cause it's not too hard with the handouts just to do the TheraBand themselves.
What is a typical stay in acute care, or what do you usually see?
It can be anywhere from 1 or 2 days. We have a whole observation wing now where if they're a G code, they'll stay on the observation unit to see can they go home within that 3-day window, or they'll get moved to the regular floor. But anywhere from 1 to 2 days to even sometimes people are there for weeks. But if they're there after a few weeks, we have a long-term acute care hospital in LTAC a couple miles away. So they may end up going there for the really long stays, but usually it's only a few days.
Okay. Yeah. How about like
before they go to rehab or subacute rehab or home health or home?
Right. Yeah. Transition to the next level in the continuum of care. How about like higher level patients? Is it harder to stay occupation based with those higher level patients? Or I guess I should maybe rephrase that. Like I have people reach out all the time asking questions about, different types of population, things like that. And that's one of the questions that people have are like, okay, we're trying to stay as occupation based and they're in acute care and they've been in acute care for a little while now and they're getting ready to transition, or there's something holding them up, let it be insurance or openings at facilities or whatever that may be. Or they'll be like a higher level patient, and they struggle with trying to stay, occupation based. Do you have any like suggestions on some little maybe ideas that they could maybe try?
Yeah, I do feel like it is a challenge for me when I have these types of patients. I'm like, okay, what am I going to do that's really hard, but it's also functional and it's not just walking down the hall, because PT, they're doing distance training and they're doing stairs. So we have like linen carts outside of the halls. So I'll have people walk all the way to the linen carts and reach down low if they're safe to do this, of course, and with the necessary assistive device and with the gate belt. I'll have them reach really low for the fitted sheets, top sheets, washcloths, walk back to their room. And if they're not wiped out from that, actually make their bed, taking off the fitted sheet, doing all that. And then like reaching up in their closet to sort the towel, put the towels up there. What else? Just kind of organizing their room, just getting out of bed and
moving and doing some of those things. Yeah.
The fitted sheet is a hard one.
The fitted sheet's hard for me sometimes. No, but, and then you have to have it, for the right person. Cause some people are like, I'm at the hospital. I'm paying them to do this.
Like I am not doing
that.
Exactly.
Okay, that's fine. I'm just trying to think, I'm trying to think walking down maybe to get or make a cup of coffee, something motivational. I'm always into this coffee thing. If anybody's ever noticed that, I have this coffee theme personally. So I like, and everybody, well, I shouldn't say, a lot of people drink a lot of coffee.
People love coffee.
Especially if you can find.
Yeah, that's another really great one.
And if you can find like, maybe not like the whole huge monstrous, what am I thinking of? Like, if you can find like a little coffee maker where you can make your own like good coffee, that might be even more motivating. And a couple other things like,
a lot of hospitals have little Keurigs too. You can just bring one of your own little K-cups.
Oh my gosh. That'd be like the most.
Do some low reaching and high reaching.
If I'm in the hospital, everybody listen to this. If I'm in the hospital, get out the coffee maker and you probably could get me to do anything.
Absolutely. Same here. Please bring multiple K-cups. Extra caffeine would be great.
I know. But another thing that I think you can really integrate in acute care is like, let's say they are transitioning to home health. Obviously, they're going to be excited about leaving. Having them pack their bag, collect their supplies. Obviously, if they're going to be leaving soon. But I've integrated some of those things into their session. They're reaching, and it's super motivating and getting everything ready to go. So that's, a couple little suggestions. Because I think sometimes, like you said, sometimes those higher level patients or those patients that have been there in acute care, because you're kind of limited by what they have in their room and like, what do I drag in? What's, sanitary procedure? Like, you know what I mean? Like there's a lot of different things that kind of.
Right. Just having to wipe everything down. So, and it really is, people are so motivated to get home, and I would say probably 95% of your high level patients will be certainly up for that intervention of getting their stuff ready and getting dressed and just getting ready to go.
Like, get me the heck out of here. And I don't blame them. And that's kind of like our goal, right? Like we don't obviously want them to be there. So it's like, okay, let's do this. What is your role in you were talking about like discharge discharge planning or help them transition to in the continuum of care. What's your contribution to that in your facility? Because every facility is different. Some facilities weigh heavily on therapy. Some, I would say my experience sometimes is not so much. And you're like trying to push for something. And I don't know. What is it like maybe from your experience?
Our hospital is pretty great about listening to therapy's recommendations. The discharge recommendations is probably our biggest factor in acute care with physical therapy. So whenever sometimes you notice on Fridays when it's the weekend and the doctors are trying to get people out, people have maybe been in the hospital for 3 days and the doctors haven't ordered us at all. And then PT and us will get a call at 2 p.m. like, I need you to see this person's stat so we can figure out where they're going. And that's not the most optimal. It would be nice if we could see them in the very beginning when they first got there. But our main thing is go in and kind of see how they're doing functionally, where were they at before, what's their home situation like, and then we make the recommendations. And every day that we see them, they may get better and better. So it may start out subacute rehab and then maybe progress to home health or home with nothing if they get really, really back close to their baseline. Right. But that's case managers are pretty good about waiting for us to put in our recommendations before ordering something. But sometimes on those Fridays, you may find that someone who is like dependent is going home by themselves with home health ordered, and we're like, stop.
Yeah.
Like, no, rehab.
I know. And those are the things that like in the ideal OT world, there's so much like ideal OT world, but I think it's super important to talk about and discuss. Like, this is not, most of the time it's not ideal. And we're trying to make the best decisions clinically and professionally, like for the patient, based upon what you're presented with. So it's not just even what the patient's, physical ability is. What is their caregiver status? Where are they living? Do they have any support? How about like, cognition or delirium or, there's all these other factors that definitely go into that. How about, maybe kind of just putting you on the spot a little bit. Is like, how do you guys I know. Like cognitive issues. I mean, is cognitive screening, from my past experience in like when I was working in a big facility, I don't, as a student, this is when I was a student, so this has obviously been a billion years ago, but I don't remember a lot of cognitive, maybe even like assessments done in acute care, or even like those patients that, are going through like a delirium kind of thing. Do they end up just staying in acute care longer, or is it like, how is that addressed, or is it addressed?
So I feel like a lot of times they usually don't stay too long. They may go to subacute rehab with that. Speech therapy, they're pretty busy with doing their swallowing evals, so they don't get a chance to do a lot of cog evals. But when they do, or if we're noticing something, they may come in and they use the MOCA. And I sometimes use the slums since it's a different assessment than what speech is using. But I think the MOCA is great if you're at a hospital where the speech therapists aren't using that exact same assessment. Yeah. And just kind of documenting during the treatment, kind of what's going on with their cognition, like what's going on with their initiation or their safety awareness, and just making sure in our outcome summary, we're really hammering on that too, so that the doctors and case managers can see that in rounds and say, oh, this person is probably not safe to go home alone right now because of what's going on with them here in the hospital. So we'll usually recommend, if that's the case, home with, if they have a really good support system of 24-hour supervision and we know that they can get that supervision, then we'll say home. But usually subacute rehab is not the worst place to go to kind of get, if they have had a UTI or something that's really affected their functioning, like if they were independent and now they're requiring a lot just because of that confusion, I think rehab is kind of a good step to go first.
Yeah, for sure. Like I just can think of some examples, and these are the cases that are hard, right? They're kind of like sticky, but like you think about those patients that everybody's like, oh, they're fine, they're doing great, and you go in there and their like sequencing is off or something, and you're like, okay, I should probably do a screen. So like like a MOCA or slums, and that's like technically a screen, but like in acute care, you only have so much time, and so like those are the realities of that. Working in that area, it's not like you're like, okay, their MOCA was terrible, I'm going to do a full cognitive evaluation to determine it. Like you don't have that
right.
time.
It's just like impossible.
Yeah, and so like you said, it's like subacute or the transition, but like doing some of those screens if necessary, I think is very important, because I think also those are the patients that get a little lost, because people say like, oh yeah, they can walk around, and you're like, but they can't sequence, or they can't problem solve, and they can't do this. And like, depending on the type of facility.
Because the doctors see them walking to the bathroom and think that they're just totally
or they're
fine.
asking about,
That's another way that we can.
Yeah. And it's just hard, because then, like, or even physical therapy say like, oh yeah, they're fine. And people say, oh yeah, they can answer questions, stuff. But like, we are looking at them from a different perspective. We're looking at them like, how does their cognitive, status influence their function? So it's not just, can they perform, but there's, as we know, as OT practitioners, there's so much more that goes into everyday occupations than just the actual physical performance of the task. And so it's just really important. But I've always found like acute care to be kind of tricky. I can think of like one prime example where I remember not fighting isn't the right word, because I'm a lover, not a fighter, but like that same kind of thing. PT said, oh yeah, they're good to go. Nurse is like, oh yeah, they can, he jokes around all the time. And I just like had this, like everything about it.
Or when like there's.
Yeah. And everything about it just didn't feel quite right. Like I felt like he was joking a lot. It was like at the stage where it was like, he knew that he wasn't quite on top of it, but he could joke about things to kind of cover it, maybe, I might be like that.
Yeah. No, but it is like that masking. A lot of doctors miss that when I'm reading their notes on certain patients, like, oh, he's totally alert and oriented and this and that. And then once you dig deeper and when you're actually doing ADLs with them and asking them questions about their home situation, and you're getting a lot of different answers from them, and just a lot of like, oh, okay.
You're like,
And then you call their family, and, oh yeah, he's living alone and doing this. And it's one of these types of situations where probably not good to go home
I
alone.
know, and it's hard, and sometimes it's really hard to quote convince them. And so that's what I always found about tricky about acute care sometimes, because you don't necessarily always have this time to do like I said, full blown cognitive evaluation, and you're just kind of trying to convince someone or a family member that like maybe they're not, they're having trouble with certain things, and like people be like, oh no, they're sharp as a tack. I love that, they're sharp as a tack. They know everything. And you're like, yeah, because you're asking them about their childhood and they can remember all those, memories. It's just a very different way of looking at the patient. So I always found those kind of patients probably most tricky, because the doctor may not catch it. PT says, oh yeah, and nursing will be like, yeah, they're walking to the bathroom, they're getting that. But you're like, actually they're, the problem solving skills really makes me question if they should go home without any assistance, or maybe we should do home health. And then also like, I always like to think my clinical judgment should be quote enough. Like, I'm a professional. I've been doing this for many years. I have lots of experience. But the truth of it is we also need to make sure that we can support our clinical reasoning. Like, why, what are we seeing? What are our observations? Are we doing maybe even, like you said, like a screen, a MOCA, or whatever it is, to kind of like quote prove that not only are we just seeing these things, but they're actually happening. Because people get defensive, and I get it, like family members. And also that puts a lot of different pressure on family. Like, you're like, they've been living alone independently. Now you're saying they need 24-hour supervision. Like, that changes their role as well.
Right.
And so there's a lot that goes into it. So anyway, those are kind of tricky sometimes, but,
that is one of the trickiest.
Yeah. But I also, in acute care specifically, I think, but I also kind of like, I love those. I'm kind of maybe weird like that, but I always really love those kind of challenging patients. I'm like, I can do this. But just.
And then when you a good accomplishment, you're like, okay, yes, like my job is important.
In
acute care,
right. Like, I am making a difference, but also like, I think what I like about it is that I feel like sometimes those patients get lost in the quote system of healthcare. And I feel like I'm serving them. I'm trying to listen to see what is actually going on, because I think that's something that we all obviously know we should do, but like, there's time and we're busy, but like, listening to what the patient's needs are and looking at what their abilities are and the support systems and everything that goes into it. I like that feeling of really feeling like, okay, that patient won't be lost in the shuffle. Because working in, I've worked in so many different areas that it's just hard, because, a patient goes from acute care to, I don't know, inpatient rehab, and inpatient rehab is like, why didn't acute care do this? Or they go into nursing home and you're like, well, why didn't they do this? Or you go into home health and they're like, what did they do when they were in, long-term care, or, like skilled nursing? What, weren't they doing anything? But we all are doing our job. We're all trying to do the best that we can. And it's hard, because the patients can't, I don't know, they feel like they sometimes absolutely do get shuffled around. And so I don't know. That's one of the reasons why I like OT. Yeah. Darn the healthcare system. It doesn't matter what healthcare system you're actually in. It's always a challenge. There's always those challenges, But if you were to give like an overview of maybe like, what are some key takeaways about acute care OT, what would you say?
One of the biggest takeaways I would say to someone interested in acute care is that while it may not be the most rehab-centric OT job, since you're not really getting to see people for weeks and weeks, it really does give you a great foundation in medicine and medical conditions. So once you have that kind of background in your toolkit, you'll be great working in any other setting afterwards, from home health, rehab, outpatient. It really is such a good foundation of medicine. And another takeaway is, if you're new, and you're having trouble coming up with intervention ideas, the best thing that you can do is just mobilize them. Like we said earlier, just get them up if they're stable. And you're really, every time you're getting them, you are making a difference with them, because they may go days without getting up if it's been the weekend and PT hasn't been able to see them. So you're really reducing that significant decline in strengthening and mobility when you're just even getting them up.
Yeah. Oh, one more
takeaway. Speaking of how we were just talking about how hard it is for us in this setting, but just to kind of make you feel better about working in acute care, check out the article, and you may have probably seen this on social media, the research study that occupational therapy is the number one kind of healthcare provider reducing hospital admissions. And that's a really exciting kind of takeaway working in acute care, is like we, with all of our holistic education and everything, I think really are a great contributor to increasing that quality of life and reducing those admissions. So check that article out. If you just Google occupational therapy proves crucial for reducing hospital admissions.
I'll add that in the show notes as well, just to have an easy link, because it is a great, it kind of just makes us all OT practitioners feel good that we're like, oh, okay, yes, we do, like sometimes you feel just like, oh my gosh, you're just doing your job. But we do make a difference. We look at people's soul from such a holistic perspective that is so important. It's not just one aspect of a person's life. It's looking at them as a whole person. Yeah.
Everything.
And it's awesome. I mean, that's why we do what we do, But I know also that you love acute care so much that you wrote an ebook about it. We had talked about before that you were on my podcast episode about focusing on occupation and occupational therapy. And I know trying to be as occupation-based as you can is important. Well, it's very important to me, but it's important to you too. And I saw that you had written occupational therapy intervention in acute care ebook. So I'd love for you to talk a little bit about it. What's it about and why did you write that?
Yeah. So when I started in acute care, just like when I started just working in adults, wow, there's really not any resources for me to see what kind of interventions I should be doing in acute care. So I decided, after working in acute care for a year, I kind of had the foundation of really good interventions. So I got together with another occupational therapist named Shoshana Shear, and we co-wrote this ebook on intervention in acute care, covering occupation-based interventions for high and low-level patients in acute care, and also covering the basics of what to know as an acute care OT or CODA, just to have that resource, because you really are sometimes kind of thrown to the wolves, so to speak, because you're on your own on the units, and you may not have other therapists nearby to bounce ideas off of, and they're in hospital rooms doing their treatments, and it's hard. So the goal was for the ebook to be a resource for new acute care therapists to have that are in that position for interventions and treatment ideas and the basic skills.
Yeah.
To be a successful acute care occupational therapist.
That's awesome. Because I feel sometimes, reading a textbook is obviously important and good, but sometimes I feel like you need some of those really practical, just a quick guide. Okay, I need something to kind of get the ball rolling. Oh gosh. And sometimes you feel a bit stuck, or you're doing the same things all the time. And it's just nice to have the variety. And also, honestly, because everything is not ideal. Everything you read in a textbook is this is ideal. We're going to do step 1, we're going to do step 2, but it doesn't always look that way. So it's nice to kind of have some resources where you can say okay, I can be flexible, or this is how I can grade it up and down. And this is very practical for where I am now. So that's cool. I love it. And I'm going to link that. I'm going to just link a bunch of things in the show notes, because I'm adding it to the show notes. So make sure you check out that ebook and see if it is a good fit for you. But anyway, so thank you so much, Sarah, for this conversation. I think it kind of gives a really good background information on what people can it's kind of looking at the good, bad, the ugly of acute care and seeing if it's a good fit, for you. If you're looking into maybe going into acute care, we're not sure, what do I expect? Is this kind of for me? Yeah, like
What
what
is
is it? Because I think sometimes actually, honestly, it's like acute care, inpatient rehab, like, and then depending on the facility.
There's so many different.
Subacute, like what, like, I don't know, kind of, but they are very, I mean, they have their own roles and they have their own features. So I love being able to kind of give people a little background information on what acute care is. So thank you again for joining. Yeah. And thanks for joining me today.
Yeah, thank you so much for having me. I had so much fun, as always. And
thanks
again.
everyone for listening. So until next time.
If you are an occupational therapy practitioner that enjoyed today's podcast, I invite you to check out the Learning Lab at seniorsflourish.com/Learning Lab. The Learning Lab is the essential resource for OT practitioners working with older adults looking for more treatment ideas, support, and resources to be the best they can be. So whether you're struggling to find evidence-based treatment ideas, you don't have time to research for resources or patient diagnoses, or are even looking for ways to earn more professional development units, then the Learning Lab can help you become a more effective and efficient practitioner. With weekly educational videos, a huge resource and handout list, a bi-monthly journal club where you can earn professional development units, a supportive community forum, and even some exclusive member-only bonuses, the Learning Lab is the perfect place to help you be the best OT practitioner you can be. It's like having your own OT help desk. So check it out at seniorsflourish.com/Learning Lab. Thanks for listening. This podcast is brought to you in partnership with the Jaros Collective, a podcast network that's redefining old and equipping healthcare clinicians to better serve our aging population. Find out more at GEROScollective.com.